decided to focus this coffee hour around destigmatizing HIV and criminalization of disease as a whole. So what is the connection between social justice and disease? When we talk about social justice and social well-being, we must remind ourselves that well-being links together the aspects of health, career, livability, and many more aspects through our lives. Social justice, for me, must present itself in reaffirming and affirming way that corresponds to my view on public health and personal health. I was diagnosed HIV positive on June 1st, 2015, and it was the second confirmatory result that I had in conjunction with a preliminary test, and I was notified during my spring 2015 semester here at the College of Charleston. I can remember vividly the sense of personal shame, loss, and hopelessness following my diagnosis. The first thing that my mother asked me when I disclosed my status to her, or the first thing that she stated was she didn't know what this was going to do for our life insurance policy. And so that's when I realized the stark need for education for all stakeholders with anybody who's going through a diagnosis. I can say that for about 2 years following my diagnosis, I am pleased to have been living HIV positive, undetectable, and healthy and happy. And I want us to consider the many societal points of duress that people living with HIV can experience. So I'm going to introduce each of our panelists and their respective titles, and I'm going to let them tell us how the struggles or issues of HIV have become personal or prevalent in their lives or their scope of work. So we have Mr. Michael Luciano, peer educator and board chair of MUSC and LAS Consumer Advisory Board. We have Kim Butler Willis, program director at the Ryan White Wellness Center at the Roper St. Francis Hospital. And we have Bennett Anthony, the dashing young adult film star. So I will let you all take it away, whoever feels that they want to start first.
Well, I'll go first. Since, you know.
Ladies first.
Right, since we have this nice sandwich up here. I am Kim Butler Willis, director of the Ryan White Wellness Center at Roper St. Francis. We talked about HIV and how it connects to what we do, who we are. So obviously, it connects to my job. The Ryan White Wellness Center is a comprehensive medical home for people living with HIV. We serve over 800 patients every year. And thankfully, not all of our patients are HIV positive. In fact, we've added PrEP to our list of services. So we have a growing number, nearly 100 patients that are HIV negative that still come to us for care, high quality care at that. I am a public health student, so I saw that we walked into that building. I have my master's and bachelor's in public health and finishing my doctorate. So public health is very near and dear to me, not just professionally, but personally. I am also a country girl. I'm from Hollywood, South Carolina.
Hey.
Yeah, and if you didn't know, I'm black. So all of those things, all of those things intersect into creating the perfect melting pot for someone that is engaged and passionate about community health, because it really gives you a different perspective and one that's very personal about caring for people that may be underserved, marginalized, or living in a vulnerable state. That's why I am. That's what I do.
Thank you, Jenny.
Do we need to swing that layer?
Oh, there we go.
All right, I can make myself heard without it, frankly. Hi everyone, my name is Michael Luciano. I should actually technically correct something because the consumer advisory boards to Low Country Aid Services and MUSC have now separated into two different entities. Those two institutions have taken a little more distance from each other, although there's still a great deal of cooperation. But also, I am now a full-time staff member, so it would be inappropriate for me to chair the Consumer Advisory Board. I do remain as the staff liaison to the board. I am a gay man, born and raised in the Bronx, and transplanted here where there's a lot less white stuff falling out of the sky. But I came of age in New York City, spent most of my adult life in the East Village, which was one of the epicenters nationally of the HIV epidemic in the early 80s through the 90s and remains so today, unfortunately. I have been positive for 31 years as of last month, and many of those years living formally with the diagnosis of AIDS. So I survived the worst years of the early AIDS crisis, often by the skin of my teeth. But in many ways, I was fortunate to be in New York City because I became immediately involved with advocacy and activism around HIV treatment. I was a long-standing member of the Treatment and Data Committee of ACT UP New York. If you do not know, ACT UP is the AIDS Coalition to Unleash Power, which was basically the original activist group dedicated to direct action, including civil disobedience, and also dedicated to Martin Luther King's theories of nonviolent protest and social change. So that put me in touch with the research from the earliest days, which is the only reason I'm still around now. I taught myself how to read the same medical journals that my doctors were reading, and I usually was able to crib copies from them once they finished with it each month. So I have a long history as an advocate for HIV treatment, and once I became well enough again after 1996 to take on more of a role than just keeping myself and a circle of ever expanding HIV positive friends alive, I have moved more towards a social justice perspective and a public health perspective. When I became severely ill, I was most of the way through a PhD in cultural anthropology with a subspecialty in medical anthropology. And I initially had a bachelor's degree in chemical engineering. So I was in a good place to attempt to attack medical journals and technical treatment information. But we've come a long, long way since then. And medical treatment was revolutionized in the mid-90s and has only become better and better since then. Today, someone recently diagnosed living with HIV has a life expectancy very close to the normal life expectancy of any other American citizen. So things are a world and a half away from where I started. Unfortunately, our social and legal policies have not kept pace with the changes in our medical technology and medical knowledge. So I am still very much a warrior and an activist for the civil rights of people living with HIV, and I can't ignore the intersectionality of that issue with issues of racism, poverty, gender bias, and so on and so forth. I mean, we could keep the list going ways, right?
All of the isms.
Yes, the isms in general. So that's my basic spiel.
Well, I am so flattered to be sitting here next to you all because I didn't even finish going to the College of Charleston before I became a sex worker, and I moved out to Los Angeles 4 years ago, lucky enough to have this swinging porn career, and started dating this guy who became positive the week I moved out there in LA. Fortunately, I didn't catch it. I immediately started PrEP, and I've been on PrEP since. So
Can you explain the difference, I'm sorry, between PEP and PrEP?
PEP is what you take immediately after you are believed to have contracted HIV. So as long as you start taking the pill within 48 hours of contracting HIV, it is said to be, I believe, 99% effective to have removed from your blood. So I was fortunate enough, I hopped on there. He also found out that he was positive early enough so that he became undetectable very quickly. So he caught it and was able to nip it in the bud. So this, 4 years ago, was definitely a scary thing in my life, but also became I was dating this guy. I can't break up with him because of something like this, and that just wasn't even thinkable. So all of a sudden, I'm not taking this pill every day. And then on the apps you get the question, are you clean or are you dirty? And it's so offensive. And it's just like, I don't give where you're from. I am from Conway, South Carolina. Never have I asked anyone if they were clean or dirty. It's like, I didn't know what PrEP was before moving out there, but I do now. And I gotta say that I'm very sex positive. I'm very for, you know, the act of like sexual things, especially since I'm a sex worker. You know, I take that very seriously. Like, I know that the only way to truly be safe sex is to be on the PrEP pill. That might be a millennial thing, but it is shown that it is so effective. So, I mean, I'm so thankful for the work that your generation has done for us, and like, I'm fighting for it as a bareback bottom as much as I possibly can, but I'm also thirsty and I'm a realist, you know, that's why I took the route that I did, but that's also why I'm choosing to live open and healthy about it, at least to my full potential, you know. Oh, good, thank you. I'm like shooken up because it's just like, it's very empowering to be able to talk about these kinds of things, and me being so open in South Carolina is such a spin-off to people.
Progressive in its own
It's
way.
very progressive. It's very progressive, you know, and it doesn't matter whether you're white or black or boy or girl or gay or straight or who you're having sex with. It's just, we should protect ourselves and our future. And as a gay man, I'm fighting to break the HIV stigma attached to gay people, attached to all people, but especially since we can halt it now, my kids won't even know about this. I feel like it'll be like the Black Plague, you know, it'll be like something because of where we are. Now they have the PrEP shot, that you can get this shot once a month, and that is like in studies, instead of taking the pill every day. You know, it's like, it's good, and I'm happy that I'm here and I can speak on that.
Can I give some education about PrEP?
Yes.
All right, so PrEP is a, for those that may not know, I think in our world we speak it every day, and so we just assume that others know. But PrEP is actually not a new concept. So PEP, our post-exposure prophylaxis, is actually readily available in most hospital systems because it's given to healthcare workers if they're accidentally pricked, like with a needle, with an infected patient. So just as we just described, it's a pill that you take immediately after that exposure within 48 hours, right? Well, PrEP has been rebranded to be that of a relationship type drug, and I like to compare it to a birth control pill.
Completely.
But you take it every day. FDA approved it in 2012, and South Carolina is just now getting on board with that. But nonetheless, we're on board. And the drug, surprising, right? And but the drug is taken every day, and it decreases your chances of contracting HIV by interacting with the virus if it does come into your body. And if taken every day as prescribed, it is highly effective, 90% plus effective. So it is the safest way to have sex, especially if you're in a high-risk relationship.
High risk, you know, it does come with some liver issues. I know that it is getting worked out. I have a friend who's on the lesser of PrEP now and says it's much better for him, but it's kind of silly, it's kind of hit and miss to who you recommend it to and who you don't recommend it to.
Right.
And what can you say about who we recommend it to and who we don't recommend it to? Like,
So you want to look at your risk. So at Ryan White Wellness Center, we're going to see what type of relationships you're in. So if you're in a relationship and you know you're positive, your partner is positive, perfect example. If you're in a relationship with many partners and you're unsure of their status, perfect candidate. If you're in a relationship and you're interested and you're positive or your partner's positive and you guys are interested in family planning the good old fun and natural way, right? Perfect candidate. So there are a lot of different ways that we strive that data to determine if it's right for you, and it's still a voluntary choice. It's not something that's mandatory, and it's something that you can start and stop. We don't advise it just because we want to keep you protected at all times, but it's 100% voluntary. And, you know, speaking from the girl that had a baby,
Right.
birth control pills.
That's right. You were gonna say.
So I'm glad you amended that a little bit or filled it in a little more, because I'm very cautious and very sensitive to the suggestion that anyone should be a gatekeeper about who should or shouldn't take PrEP.
Sure.
Aside from if you have a physical contraindication.
Completely.
Many prescribers will not give PrEP to someone who isn't in a committed, monogamous, serodiscordant relationship, meaning one partner is positive and one is negative. That's a judgment call, and it's really not the place of the prescriber to make that judgment.
I agree.
So I wanted to be sure
Yeah.
that
It's very different in LA, which is unfortunate because you just go in, like, they just hand it to you, you know.
almost.
Yeah.
And one more question regarding that. What do we think would spawn a physician to not, like you say, provide it to someone? What could we think as healthcare professionals would be one of the most contributing factors as to why a doctor would not?
So in the hospital system, we found initially that it was just lack of knowledge. So not knowing exactly about the drug, how it interacts with other drugs, how it, if it's safe or effective for different age groups, different other chronic conditions. So just not knowing, and not even, unfortunately, providers aren't always required to continuously learn new and innovative strategies to healthcare. And so that's why it's important that we network with other providers like primary care people. So if you do have a question about PrEP, we found that they've just started referring their patients over to us versus becoming the prescriber themselves. And that's something we can monitor, and we can send that patient back over for their general healthcare needs. But I really think it's knowledge. The second subset, and I think it's a smaller percentage, just because I'm feeling positive today, is shame and stigma. Yeah, so, you know, those judgment calls like Michael just talked about. And unfortunately, that's just the way of the world.
Yeah.
And I mean, well, maybe I'm not quite feeling so positive today, but I have seen that there is a significant barrier to providers giving access to PrEP, because they are, in a sense, gatekeepers. It is by prescription only, which means you have to have an MD or a nurse practitioner sign a prescription for it.
That sucks.
Well, yes and no.
Well, yes and no,
I mean, there are reasons that it is a prescription-only drug,
Right.
but there's no guarantee that a prescriber has any sort of progressive outlook, or even there are prescribers who will say even in committed monogamous serodiscordant relationship, they will not prescribe PrEP because they don't believe people who are HIV positive should be having sex unless they're using a condom. In the Bible Belt, in South Carolina and our neighbors, there is still an extraordinary level of stigma associated with HIV, including at times from the medical community. And I have to actually credit Kim and Roper's program on PrEP, because one of the other big barriers is insurance and the ability to pay for a very expensive medication. The medication itself is not so hard to get because there are patient assistance programs, but you still have to pay for doctor's visits, lab tests, and ongoing care, which can be very expensive. And Roper does subsidize that for people who are uninsured, so kudos for that.
So if you ever see us selling anything, buy it.
Before I move on to the next topic, I want to ask anyone from the audience or the panelists if you had any contextual knowledge about what laws look like referring to HIV or any STDs for that matter before you guys, or we talked about these specific statutes. Did anyone have any knowledge about HIV, the laws, or if there were even laws about HIV in our state code of laws? Did anybody have any knowledge about that? Did any of the panelists have any knowledge about that?
I didn't. I'm not too saying that.
You can tell me what knowledge you did have about it, and then I'll specifically go into what we're discussing.
Specifically what knowledge, or in what context?
In what context,
So
yes.
among too many other programs, I've run a program called Healthy Relationships, which is considered a high-impact prevention for positives program, meaning it is designed to help HIV-positive people be sure not to transmit the infection to others. And as part of that curriculum, as well as in support groups and other educational groups, we discuss what South Carolina law is. Invariably, 99% of our clients are not aware until I talk to them about it, what South Carolina laws are. And I do not ever pressure anyone to disclose their status because although I've made it, I'm as out about my status as I could possibly be. I have been in every newspaper and on every radio station and television station in Charleston and most of the ones in New York City. But it's safe for me to do that, and I've spent many years making sure it's safe to do that. So I don't ever pressure anyone else to disclose, but people do need to be aware of the law, and that law is deeply problematic. But we'll go into more of that.
Okay. So I attended a conference in Washington, D.C. Through We Are Family and the Alliance for Full Acceptance. It was the annual Creating Change conference. And one of the sessions that I attended was a session on the criminalization of disease. And we did a case study for an exotic dancer in the state of Michigan and another case study in the state of Tennessee. And this dancer was dancing at a club that was raided on drug charges. She was arrested for simple possession and then interrogated about any of her relationships with any of her clients. They then tacked on additional charges because she was HIV positive and detained her even though none of her clients contracted it. And so I thought that was very problematic because I'm like, you're punishing someone for a crime they did not intend to do, nor did they actually commit. So then I went upon further research for the state of South Carolina. And guess what I found? So in the South Carolina Code of Laws annotated, Title 44, which I believe is the health title, Chapter 29 and Section 145, specifically about HIV, the exposure of HIV in this state is punishable to up to but no more than $5,000 and up to but no more than 10 years in prison. Prosecution and sentencing is not contingent on the intent to transmit, neither actual transmission of the virus itself. These state laws are antiquated and have not been amended since the early 1990s, when we were experiencing the height of the AIDS epidemic nationally. The statutes have not been brought up to speed with the findings from the Center of Disease Control, the CDC, concerning viral load suppression and HIV positive but undetectable individuals. And it is time to hold an important dialogue, which we are doing, about holding our legislators accountable for being mindful about the negative impact that this code of language leaves in these laws. So we're going to move into our panel questions, but I want to ask anybody if you have any comments, concerns, or anything to add to that statement along with that specific statute that I cited.
I think this law only supports every other healthcare law, sexual healthcare law that we have in South Carolina. They're all pretty dated. I know the Comprehensive Health Education Act, which we use to determine how we'll provide sex ed to our students in our state, it was last drafted in like 1989. So, right, exactly. Were you guys even born in 1989? So, and sex has definitely changed since 1989. So we have a lot of work to do on the sexual health front in South Carolina, especially given our stats, and stats are staggering. If you don't know, the federal government has now deemed the Southeast, and especially the Deep South, as the new epicenter of the HIV infection. So, I mean, what used to be California and what used to be New York City, and even still in DC, but I mean, those used to be our hot spots. We're now in the Deep South, so South Carolina, North Carolina, Louisiana, Mississippi, Florida even. And it's things that we can do that we've learned from our other states that could easily be ratified, but we need you guys to do it, to help make it happen. Yeah?
Yeah, you're right.
And what would you, I'm sorry, go ahead, Michael.
I did have a comment on this, actually.
Yes.
This opens up a big-ass can of worms, which is that this code and subsection actually do not talk about exposure to HIV.
They talk about possible.
What is criminalized is the act of having sexual intercourse, sharing needles, or practicing, or
You're right.
being a prostitute. If one is HIV positive and does not disclose one's status. So it doesn't take into account exposure or the lack thereof. It doesn't take into account whether or not a condom is used. It does not take into account whether someone's viral load is undetected. There's a big difference there.
Right.
Or if someone is on PrEP or not. Sorry, throw that in there.
That's good.
So what effectively becomes criminalized is a person's HIV status, not an action that they take. And that is deeply problematic from a civil rights perspective, from a social policy perspective. And it's simply not in line with our medical knowledge at this point in time.
Yeah. In the car here, Topher and I were talking about the case where I think back in 2009.
It was an online case.
Yeah, 2009, two neighbors got into a dispute. One neighbor bit the other neighbor, because it's South Carolina, right? And the neighbor that bit the other neighbor was actually HIV positive, and he was charged with, what was the charge?
Intent.
Intent?
To,
I can tell you.
Assault charge, basically?
Yeah, assault with intent to kill.
yeah.
Wow, and that carried, what was the sentence for that, did it say?
It didn't say on this handout right here, but that was the charge.
That's ridiculous. I mean, it's also a ridiculous situation.
Think about assault with intent to kill. Think about what kind of punitive measures.
2009, and HIV cannot be transmitted through saliva, so.
Right.
And we knew that well before 2009.
Right, so.
But that is an actual case law now. That is something that happened. Someone was convicted for that, for biting. And we're going to get into some more in-depth questions. The first one we have is, how and when did you first learn what HIV was? And what was the social political climate at the time of your exposure to this knowledge? And this goes for anyone on the panel.
It was like 6 years ago. I would have been like a sophomore at the College of Charleston. I was playing on the gay rugby team here. And I was about to hook up with this guy in the bed, and he was like, I can't because I'm positive. And I was just like, I don't even know what that means. Like, okay, but even though he was on his meds, I remember him telling me he was on his meds and that he was undetectable now, and I couldn't go through with it because I was so ignorant at the time. But yeah, I have to say that's when I first came about. Yeah, I have to say that also it's so bizarre. I guess because being raised in the South, a lot of the work that previous generations have put in was not publicized to me. I had not seen Fu Manchu or Paris is Burning or any of these movies that glorify all the work and all the things that we've done until I moved out to Los Angeles. I mean, I remember even being like, I can't watch RuPaul's Drag Race, even before, like, in college, like, it's just too much for me. Which is so bizarre because I love it and watch it every day now, but it's like, it's yeah, it was kind of funny that it took me to get, like, I guess 22, 23 years old before I got the ball rolling on the knowledge. But like I said, and like we've said, in South Carolina, it's not really, like, glorified here.
Not a priority.
Right, yeah, it's definitely something that's swept under the rug, but that's where we come in.
Yeah.
Yeah, to kind of teach people about these things, I guess. You know.
For anyone else, when did you first learn about it? What was the climate in life?
So not as sexy in the bed. I went to USC up in Columbia, and go Cox, no pun intended. And my first year there, I went to school. I was very interested in sexual health, but teen pregnancy prevention. That was kind of my angle. And so I joined a peer health advocacy group, and that peer group then led me into the field of STIs and HIV. And as a campus-wide event, we did free HIV testing. So this was my opportunity. Here I was walking around campus with, like, condom earrings, like I was totally TLC out, okay, because I was serious about it. I had a condom belt, it was thorough. But yet I had never been HIV tested, and so I didn't want to be a hypocrite, so I thought this is my opportunity to practice what I preach. And so I went to be HIV tested, and back then it took a week for your results to come back. Can you imagine? I was like, and I don't even think I was like having sex with a whole lot of people, but Lord God, it felt like 10 million at that day. And that was the worst experience, because not only was it my first time, outside of the education that I learned in my peer group, that's all I really had. And then the woman providing the test, she seemed to be pretty judgmental. Like it wasn't a comforting or positive experience. And so even if I learned in that week that I was indeed positive, I would have never gone back to her.
Exactly.
So from that experience, I then said, I'm gonna make this better for the next person. And so that kind of just started my whole crusade. Yeah.
Oh. What year was that?
Really?
Because you're making
2000.
me feel old. Oh, jeez.
Thank you.
I want pictures of the condom outfit.
Masking tape and condoms.
So I had heard a little bit about the gay cancer before this, but the first real exposure to knowledge about HIV that I can recall was in my junior year in high school, which was a long time ago. So that was 1982. If you know your HIV history, 1981, June 5th, 1981 specifically, is the date when HIV, well, it wasn't even known to be HIV at that point, but when an illness as yet unnamed at that point was killing gay men. So in high school, in my English class, we were required to do a speech on a controversial subject. And a classmate whose older brother was gay, spoke about HIV. And, I'm sitting on my desk, not out about my sexuality in school, although, well, never mind. And not denying my sexuality in other forums. Knowing that we're talking about me and my people, and we don't know shit at that point, quite frankly. It was called Gay-Related Immune Deficiency, GRID, because they hadn't yet identified the virus and didn't make the name slightly less stigmatizing by calling it acquired immune deficiency syndrome. So it was a big shock to me to realize that these rumors that I had heard about and these things I had heard about were a threat to my own life and to my community, really. My budding community, since I hadn't really become fully a part of the gay community in New York at that point. I wasn't mostly not out. So, and as far as the social and political climate at the
Especially
time,
being in high school and being in New York at the time, explain what that was like.
right. Everyone had heard at least a little bit about what we later called HIV. New York is very varied. I grew up in the Bronx in a sort of borderline neighborhood where it was not really acceptable to be out and to be gay, at least not to be obvious
Not in the
about
Bronx.
it. But myself and other friends, including lots of straight friends, we would hop on the subway on the weekends and go downtown to Greenwich Village. The East Village at that point was still sort of off limits because it was a very, very poor neighborhood, at least at that point. It had the effect of spiking up the general atmosphere of homophobia, making many people feel justified, as some people still do, that, oh, well, those gay men, they're diseased creatures. Reinforcing the idea that had really just barely been changed in medical practice that homosexuality was a medical disease and a mental illness that had really just recently been reversed at that point. So there was an enormous amount of fear and stigma attached in those early years. In New York, in many ways, it got better in the years after that, just because the actual cost of the epidemic in terms of the lost lives of artists in particular, musicians, people who were valued to the New York community, to some degree humanized the AIDS epidemic, and things became somewhat better, although there were still a lot of problems. One of the very first protests that ACT UP did was at the emergency room of St. Vincent's Hospital in early 1987, which had refused to treat a man with HIV the night before, and simply forced him out of the emergency room. Of course, the security guards double-gloved and so forth. St. Vincent's Hospital later became the epicenter of treatment for HIV in New York City because it's in the West Village. So things did change, but for many people, and certainly outside of New York, San Francisco, Los Angeles, etc., that stigma has never disappeared.
It's funny that you brought up the platform that artists use in order to get the voice out. My first encounter with what HIV or AIDS was actually was the first death I experienced, and that was from my Uncle Anthony. He was a soldier in Germany for about 30 years. He was dating a German woman and hung out with a very eclectic group of friends, and contracted while he was overseas, and felt as if he could not talk to anybody in their family about it. So I saw how he was shunned when he got home. I also saw how his health deteriorated because I don't believe he had acted, or he may have been overseas too long for him to have been able to save what left of his life. What left of his life he had. And so it had progressed too far, and I remember him passing away, and then I found out later that he was a poet under the pen name Snowball because his vice was cocaine, and he did not feel like he could confide in anyone. So that was a very early experience, me walking into his room that we were cleaning out after the funeral and seeing a pamphlet that said AIDS on the top, but I had to have been like 7 years old. And it was a devastating pamphlet. It did not look welcoming at all. Imagine that. And so that stuck with me. It resonated with me for years because I still didn't know what it was. No one was willing to talk about it in the family. Nobody discussed it at all. All I know is he got very sick and he died. And that stuck with me for a while. But like I said, it's about education and communication. It's about instilling education specifically in marginalized communities, I feel also. I want to talk about marginalized communities for a second. Do any of you know or have statistics on the most heavily affected demographic by HIV within the state of South Carolina? Compared to the US or the Low Country, do any of you know the stats and what are the most affected groups within the state?
So nationally, and unfortunately, African Americans, and especially African American men that have sex with men, are the most affected group when we talk about HIV and HIV care. And unfortunately, they're least likely to engage in care. I love to hear Bennett's story. He said he's on PrEP. That's amazing. Now, how do we roll that out to African American communities as well? Because generally, when we see a PrEP patient or someone being more proactive about HIV prevention, they're hot like this. You know? So we want to get some Black guys in too,
Yeah.
to make sure that they're taking care of themselves, but the African American community, if we're talking about, that's numbers. If we're talking about rates and the fastest growing, African American women. So African American women are 20 times more likely to contract HIV than their white peers or white counterparts. That's alarming. And I would say that it's because of a long list of antecedents that just intersect and create that perfect storm, right? But yeah, so nationally and locally, it's the same, it mirrors. So there's a lot of work that we can do in our African American communities and still a lot of work that we can do in our LGBTQ communities as well.
Michael, I feel like I knew some or heard about some stats regarding North Charleston. Do you know, or do any of you know, how much higher or the exposure, the risk, or the problem that's going on in North Charleston?
Yeah, so unfortunately, our North Charleston data comes in as a composite. So it's a metropolitan area. So it's kind of hard to differentiate between the two. And in South Carolina and a lot of rural states, we are a rural state, our people are very transient. So just because I live in North Charleston doesn't necessarily mean that I was tested in North Charleston, nor does it mean that I received care in North Charleston. So it's hard to kind of pinpoint exactly where infections are, but we know just from experience, and I'm looking at Jessica, she's our Walgreens liaison, but we know that North Charleston is a hot spot for so many issues, to include HIV, compared to like Mount Pleasant. And that's, once again, goes back to the population. We know that there are more African Americans in North Charleston than it would be in Mount Pleasant, or West actually. So that could be a reason too. Poverty is high in North Charleston, so that's another confounding factor when you think about HIV. But Charleston, North Charleston ranks within we're consistently in the top 25 metropolitan areas in the country for HIV/AIDS infections prevalence. Anything to add to that?
Only that I will add to that so Low Country AIDS Services is located in the 29405 zip code, which is the south end of North Charleston, right above or right next to Chicora and Chickadee. And we have seen for several years that our largest number of positive tests come from our own zip code and 4 adjacent zip codes. But we also, so I did a geospatial mapping project 2 years ago now with a physician from MUSC and the Department of Health's medical director. And we found that there is a corridor of infections, right, so the residence zip codes of people newly diagnosed with HIV in the year prior to doing that project were concentrated in a corridor from the northern end of Charleston straight up 26, basically past Orangeburg and up towards Columbia.
Yeah, really?
And unfortunately, when you plot that against where testing sites are available, there's a huge red zone where people live who have tested HIV positive and presumably are, having sexual relationships somewhere near where they live. They may come into Charleston or Columbia or Orangeburg, for a weekend or whatever, but ongoing relationships are most likely closer to home. And testing is simply not done there on a routine basis. There are few providers who are actively offering testing.
Yeah.
It's unfortunate. The undercover brothers.
Yeah.
And it comes with shame.
It does.
And the only way to fully protect yourself is to protect yourself. You can't control what anybody else does. I got an offer to shoot a movie last week, and it's like, heads up, there's no testing involved, this is what they get paid, this is what they get paid, and I'm just like, I can't believe that you think that, that you testing the other performers is going to result in how I perform or how I guess react to the situation, because I don't care what any of them do. I'm just protecting myself.
Ross, this question is for you specifically. How have you, I know you mentioned this a little bit right there, but how have you managed to own your protection in a self-fulfilling manner in sex working? How have you managed to, because I'm pretty sure...
My mom accepts me, so I don't care what anyone else thinks about me.
Amen.
That's right, God bless her. I'm actually driving to Myrtle Beach to see her after this, so she's cool. Being able to own up to that, being able to say that I take the pill every day, that definitely helps me like put my foot on the ground as far as like, I'm doing what I need to do to be sex positive and protect myself and protect the people around me. I definitely approach it in an education sense, like I was saying. It really ticks me off when people approach you, with that like, are you dirty or are you clean question mark, and like, even though I am negative and that is completely unrelated to me, that is still so rude, and more or less I'm like bothered because I have to waste my unlimited text messages to like educate them for the next hour why you don't tell people that, why.
Taking the pills. Now, there's a different feeling associated with a preventative measure and then a post measure, taking a pill every day. And so I can remember feelings of shame, depression within myself. I'm gonna have to take this pill daily for the rest of my life. Even though literally it's like a horse capsule. It's very unbecoming. You have to take it every day along with all my other medicines, my allergy medicine. But accepting the fact that I have to take it every day was a very big step in my own journey, because at one point, post my diagnosis, I didn't go and seek treatment at all. I didn't tell anybody. I didn't go and seek treatment. And actually, I think I got a little more destructive with myself before I got better. And so I wanted to ask Michael and anybody else who can answer this question is, do you notice a trend following new diagnoses at LAS specifically? And how have you viewed clients' willingness to return to treatment for their diagnosis? And how have you viewed that pattern cross-culturally?
So, until about a year ago, my office was actually directly across the hallway from the testing lab, and I was often brought in to talk newly diagnosed folks down off the ledge, basically, or just to bring them down and say, look, I'm still here at that point, 30 years later, giving shit to everybody. So, if I can do that, having lived through the many years when there simply was no treatment available, you will be here 30 years from now. And I say, without hesitating, you will be here 30 years from now, because the vast majority of them are young men and women. Just as a miniature sample, in the month of January, we were only open 15 days because of the snow apocalypse and the holidays. And we had 7 new positives in January, one every other day. Effectively, they were a little more clumped together than that, but effectively, one every other day. All of whom, the oldest of whom, all of whom were men, and all of whom were men who have sex with men. The oldest was 29.
Wow.
All the others were 24 and under, including 2 17-year-olds. So that's the general trend of what I have seen over and over again for the last at least 5 years at Low Country Aid Services. And that reflects the national trend as well.
Yeah, so LAS, at Ryan White, we do a great job at CARE, but LAS does a phenomenal job with outreach and testing.
Yeah.
And so generally, when they have patients that they can't care for, they'll send them over to us. So it's a really good partnership that we have, because we won't compete over patients, But I think sometimes at our center, we become so focused on the medical care of that person because we just want to get you well and get you well quickly. But there are so many different layers that a newly diagnosed person is dealing with before they can even address their medical issues. Right. And we'll be fortunate enough to even have someone come through our doors that's stably housed, that employed, that's fed, that, I mean, it's so many other social determinants that really affect a person. So I think you guys do a really good job with counseling on that front, and that's something that we've really become focused on at Ryan White, making sure that we're trying to address, Maslow's hierarchy of needs. Are we meeting the patient where they are in their journey? So even if you come to a medical appointment, we may not prescribe medication for you the first day. You're not ready for that. You know what I mean? Maybe it's about getting you into a home first. Maybe it's about getting you connected to the food pantry first. Let us help you meet your needs so that we can meet our common goals. And something that you said, Bennett, I love your passion for those that are positive. I just wrote down here status privilege. We have the privilege of being negative, but it's going to take people that are negative shouting for those that are positive before we can see change. So almost like the concept of white privilege, right?
Completely.
You need white people screaming for equality. So the same way in HIV care, you need negative people screaming for it as well.
It is very much a challenge, and it's very much the same things that Kim just mentioned, all of those other disparities, including, for many people, a lifetime, maybe even multi-generational disconnection from the traditional healthcare system, and often distrust of that healthcare system. We're not far away from the place where the Tuskegee Airmen experiment happened.
That's right. That's right.
Not far at all. So there are many challenges. Some of the things that we have done and that other places have done as well to try to beat back some of those challenges or get over some of those hurdles we have had a linkage to care manager for 6 years now. Which was an entirely new concept at that point in time. Someone who specifically dealt with newly diagnosed, a case manager effectively, who specifically dealt with newly diagnosed folks and gave them extra attention. Her caseload was limited compared to the other case managers so that she could provide more support to try to ensure that people did not fall out of care within the first 18 months. Generally speaking, if we can engage someone well for 18 months, they're much more successful at remaining engaged lifelong. In addition to that, I volunteered, I can't even begin to guess how many hours as a peer counselor before I actually got paid for any of it. Woo-hoo. I was able to do that because I was on disability for a long time. So I am now employed full-time, as is another peer counselor, and our first duty is to work with newly diagnosed folks. We work with, my caseload is 400, and currently 473 patients, because every client at the agency is my client. But formally, as far as the job description goes, and a lot of my efforts over the last 8 years have been directed towards newly diagnosed folks. And having a peer to step in at that point makes an enormous difference. As you well know, Roper employs peers also.
Yeah, so starting back in 2014, we took a few of our patients and trained them, provided professional development opportunities to help them become just as great as Michael is in his job. And so we have peers that meet with every new patient. So unlike some other programs, we case manage all of our patients. So all 800 plus have a network, or what we call a care team. So you have your provider, you have a case manager, and you have your peer. And you would be surprised by the amount of information that a peer would get that the doctor would not, and that the case manager would not. And it's so interesting when we all sit down in those team huddles to hear that Mr. Johnson told you this, but he didn't tell Dr. Minnick, but he told Lisa this. And it's also interesting to see what's the tea going on in these relationships. Like who's with who, who's not with who. We can't tell those people because we have a lot of partners as well. So making sure that we're mixing up the care team so that there's not an opportunity to cross exchange information and
16.
disrupt any households. We are not in for that.
Yeah.
But it's interesting just to hear the dynamics and understand how our patients live outside of their medical care, but really understanding the social components of their life.
Okay. This question is going to be interactive, and this goes for, I really would love anybody in the audience as well as the panelists to provide their input. I've asked if you had to change the statutes for the state of South Carolina as they stand, because this was the activity we did at Creating Change. If you had to change them as they stand, what would you do? What wording would you use, or what marginalized communities would you be first to take into consideration for a protected class? Do you feel that there is even a need to reform? So anybody just throw out there what they would do to change it.
I'm no legal specialist, of course. I know for giving blood, if you identify as a gay man, you have to have 12 months of celibacy to give blood. And I don't know what statute that falls under, but I find that as a hindrance that needs to be dismantled. But I don't really know. I went to the Gay Men's Health Crisis Center for spring break, and Eric Sawyer, another member of ACT UP, I believe, he was talking about how they were trying to talk with some legislators about reducing that time frame to 2 to 3 months, because I think in the UK they reduced it to 2 to 3 months.
Wow.
But there's a lot of
It's 90 days.
yeah, like something of the sort. So, but there was a lot of pushback for that.
I can remember prior to when I was diagnosed, those are specific questions that they asked if you were a gay male and if you were having sex with men, and automatically, within a certain time, if you answered yes, you were disqualified from being able to give blood. I remember that.
Almost as if it's going from donor straight to a recipient. That's
Which doesn't happen.
ever.
And that change to a 12-month celibacy requirement is quite recent, actually. 2015, if I am recalling correctly. Prior to that, and that was late 2015. Prior to that, if you admitted to being a gay man on the questionnaire, you were immediately disqualified. And as far as how to change that, that is regulated by the FDA. They are the ones who issue the policy around blood donations, and it would be a lobbying effort directed toward them. And what's especially distressing there is that, you know, the FDA is largely, it's not always true, but largely made up of scientists who know.
Apparently sexless on it.
Well, maybe that's why they want to pass that surgery. You know, they have and have had for many years accurate information that should counter that ridiculous and stigma-driven time limit, because we can test for HIV, the most accurate rapid tests with just a finger stick of blood can detect HIV within 10 to 14 days.
Wow.
12 months is a preposterous period of time to impose a ban. Not everyone will develop antibodies to be detected within that short a time frame, but at 3 months, the possibility of the blood, which is always screened, always, and it's screened for much more than just HIV.
Right. And continuously, it's not just a one hit.
There's virtually zero chance that a batch of blood that could transmit the infection would not be screened out in that process. That's where England arrived at that 90-day figure.
So we can agree, sorry not to cut you off, we can agree that we should take off anything that considers blood transfusions within that statute. Is that a general consensus? Okay.
And they don't ask, you know, they say you have to be celibate. They don't ask, well, did you have sex within the last 12 months, but you're on PrEP?
Right.
But you used condoms consistently?
Yeah.
You know.
That's another question about revisions that sparks my interest. Do we feel the need to lobby for contraception and PrEP to be a means of defense. How do we feel about that?
I'm all for it. I'm
Yeah.
a teen pregnancy girl, so you know.
Yeah, I mean,
Yeah.
in a sense, someone who's taken PrEP, the PrEP, I believe, is really doing a lot in the movement towards safe sex. You know, it's like, it's not easy to get, but it's not hard to get. And so you kind of have to choose your battles. You know, I'm not using condoms ever, so
Right.
I will be on the pill as a kind of a thing. But you know, for some people, it's not the end of the world. You know, so it's just good to be proactive in no matter what form you're doing it. If you are going to use condoms, and I'm fully fledged not using the pill and not using PrEP, but I have to say that as far as you know the studies go, and more research comes out, more and more research comes out, and I just found out, like, you know, a few months ago, I don't even have to take the pill every day because I've been taking it every day for 3 years. I can take it every other day because there's so many antibodies built up in my system. It's great.
I absolutely applaud you for that attitude because sex does not just happen with one person.
Well.
There's a version of that. But if we're talking about sex that might possibly transfer HIV, syphilis, gonorrhea, chlamydia, whatever, there are two people involved, at least.
That's right.
Right?
That's right.
At least
You both,
minimum.
yeah, you both adhere to some sort of
Therefore,
risk.
there are two people who have some responsibility to
Correct.
prevent the transmission of HIV, syphilis, gonorrhea, chlamydia, yada, yada, yada.
100%.
There are two people involved there. Oh no, I don't know about you, but I'm HIV negative. We are going to use condoms. Or I'm going to get a prescription for PrEP, which is, you know,
Doable.
the most, it's doable for most people.
Right.
And thanks to Roper here in Charleston, it's
Right.
doable for pretty much everyone.
Right.
But that is
Granted,
taking
yeah.
an active role, protecting yourself,
Right.
rather than blaming someone else
Right.
or laying 100% of the onus on
Right.
that person to protect you.
Right.
I mean, do we expect in our, you know, dog-eat-dog world, do we expect other people to take 100% of the responsibility to protect us from anything? No.
It's like saying, I'm not gonna wear my seatbelt today because I know everybody else is out there looking out for me.
Right, everyone else is.
Yeah.
Not on these streets, they're not.
Yeah.
You know, and I would say that is an argument for completely abolishing HIV-specific criminal laws.
I agree. That is something to move forward to, abolishing the HIV criminalization.
And see, this is
Yeah.
where it strikes the fire in my heart, being a person affected by HIV personally. I don't know how successful I'm going to be with this and who all is going to help lobby with me, but my intention is to become a part of the student legislature so I can go to the SC fall session in Columbia and bring up this matter, because the first step is for it to even be spoken about in the House. And so that is my intention, is to harass them until they see that this is problematic and this is another form of coded language that needs to be revised and brought up to date. So wish me luck on this. I don't know where it's going to lead me. I know I'm going to meet a lot of good people on this journey, but this is going to be hard, especially for this state here. But it's something that I've been thinking very long and hard about for a while now.
I genuinely believe that this is going to be the generation to end HIV in the Low Country. The fact of hearing that on spring break you went to the HIV center. I mean, the fact that you guys are in here today and it's beautiful outside and we live in Charleston. I mean, I think it's a testament to the amount of passion within this generation about just social justice issues, and I am so in love with it. So if there's anything that we can do at the Ryan White Wellness Center to support your efforts, please give us a call.
I need a job after I graduate.